Well, hello, everybody. My name is Garrett Schmidt. I'm the CEO and managing editor of VBC Exhibit Hall, and I'd like to welcome you to today's live webinar hosted by Nimble. And it is called the $280 PMPM problem, the hidden cost drivers of musculoskeletal health conditions. This is a topic that doesn't get a lot of attention, but is fascinating and definitely needs more exposure. And so we're going to do that today. A few items of note before we get started. Everyone has joined today in listen only mode. So this is a traditional webinar format, so we can't see you or hear you. So don't worry about having to turn off your mic or camera, but we do want to hear from you. And so we're going to have a dedicated time for some Q&A at the end. But if you have a question at any point throughout the presentation, go ahead and drop your question in your attendee module, and there's a place specifically for questions. We're going to get to as many of them as we possibly can. If for some reason we don't get to yours, don't worry, someone will reach out via email to make sure that your question gets answered after the fact. Also, today's session is being recorded, so what's going to happen is when we conclude, about an hour or so afterwards, you're going to receive an email, and there'll be a link to where you can rewatch the recording as well as download the slides. And we hope that you do so and share it with colleagues and friends. That link will be good for a while. And then without further ado, I would like to introduce our speakers today so we can jump in. With us today, we have Mr. Edward Likovich. He is the CEO of Nimble Science. And then also Dr. Donna Baldwin. She's the Chief Medical Officer of Nimble. So welcome, you two. Great to have you today.
Thanks so much, Garrett. We're thrilled to be here. We can see the rooms filling up with attendees, so glad to have you all here. I want to reiterate what Garrett said. We want this to be interactive. We have a lot of fun in the conversations that we have, and we're all going to learn some things today. So feel free to put your questions in as we go. As Garrett mentioned, my name is Ed Likovich, CEO of Nimble. I founded Nimble because of what happened to my grandfather, who was an immigrant to the United States, suffered a severe fall, and got a TBI, messed up his knee, never got back on his feet again. And so these issues of MSK and falls are near and dear to my heart, and we're working hard every day to prevent those and make sure that others don't have to experience that. I'd love to introduce my co-panelist today, Dr. Donna Baldwin. Tell us about yourself.
Yeah, thank you, Ed, and thank you, Garrett. I'm Donna Baldwin. I'm a family medicine physician, been practicing for 25 plus years, and really am passionate about our aging older adults. And so joined Nimble not too long ago as the chief medical officer to really create the world that we want to age in. And so super excited to share what Ed and I have learned and how we can really impact our aging older adults. So excited to be here.
Thanks so much, Donna. I love that phrase, create the world we want to age in, because that's what we all aspire to, and we're going to talk through that today. So in terms of outline, we're going to start with MSK and just talk about the landscape, really some of the challenges with it. MSK has been sort of a buzzword. Everybody's been talking about it. A lot of health plans and health systems have a strategy around that. But we're going to sort of look at different pieces that maybe aren't as thought about on a day-to-day basis and where we see real opportunity. One of those is going to be the problem of falls, which, as I mentioned, is near and dear to my heart. And it affects so many lives, but it also impacts the bottom line for many organizations. And then we'll talk about how all this aligns within a VBC model. And again, at the bottom here, it says Q&A. We can do it at the end. We can do it as we go. So just click on that question tab, put in your questions as we go, and we'll answer them. And then we have some fun interactive polls as we go along here too. So thrilled you're all here, and let's jump straight in. So when we think about MSK, the title of this was a $280 PMPM problem, and I think that's an important number because it's such a huge cost driver. We've picked out a couple important aspects of MSK in this chart here that you can see, and I want to talk about a couple of them. The first is that MSK is a top 5 cost driver for every plan, $380 billion annually. This is a huge number. And I think that sometimes we can get lost in those numbers. I always like to think about the human aspect of this, because when we think about our lives and the lives of loved ones, we all know somebody who's had some sort of MSK issue. It's prevented people from going to work. It's prevented people from aging in place. They have to go to some sort of skilled care. All of a sudden, cost escalates. And it's one of these things that just is this vicious cycle where if you get caught in it, and the right intervention doesn't happen, it gets worse and worse and worse. And you can see some of the other points we have here around, a lot of the MSK program is focused on those interventions versus prevention. And I think that that's an aspect where we can get stuck as well. We have to get upstream of this and look at how do we prevent these things from happening versus just, oh, something hurts, you're losing your functional mobility, let's send you to PT. And then the last thing I want to talk about, and then Don, I'll turn it over to you, is this idea of the intersection with MSK, chronic pain, mobility, and aging. Uh, what we see among our older adults is when you lose that ability to move, when that pain interferes in your life, you lose the ability to live independently. And everybody knows that an independently living person is a happy person. They're engaged in life. They're getting the care that they need. If they lose that ability to be independent, all of a sudden there's where that cost ticks up. The quality of life goes downhill, and you get trapped in that cycle that I mentioned earlier. So Donna, seen a lot of patients over the years. Tell me about this and kind of how you've seen that version show up.
Yeah, I mean, I think a lot of this resonates for sure in my practice. I think, as my older adults come in to see me, whether it's for, their annual wellness visit or, because they're having any issues, I think, that fear of falling is definitely real. And so whether it's, a 73-year-old that I'm talking to about osteoporosis who's afraid to go out of her house because she doesn't want to fall and end up in the hospital and totally lose her independence. I think the other thing that I think is really interesting that I've seen is those patients with those mild cognitive deficits. So whether they have early onset Parkinson's, whether they're depressed or anxious, I think those are probably some of the higher risk of falls that we don't identify because there is a cognitive relationship between mobility and balance. And so I think it's really important to consider that. The other frustrating thing is I identify somebody who may be at risk of falls or even just somebody I want to talk to about maintaining their mobility, and I really don't have resources for that. I could maybe encourage them to go to the gym, but who goes to the gym? I don't have a gym membership. So I think that's really difficult, especially for that example that I gave you where she's just afraid to get out of the house.
Yeah.
Um, Additionally, I think it's something that I can, encourage them to see physical therapy and maybe get a gait analysis. But that's like a 1 or 2 person visit. And then who holds them accountable and how do they continue those exercises when that's really a challenge for them? So I think really kind of figuring out a solution that can be easy to apply that doesn't take much effort, I think is really why I'm excited about Nimble.
Donna, you said something interesting there, which is about this cognitive piece. I think when people think about MSK, they're thinking about joints, right? And physical function. Tell us more about that. How does that interplay with the problems of MSK?
Yeah, so it's well known in the physical therapy literature that your cognition is a part of that balance reflex. So, as you kind of lose that, and in fact, you start losing it at 35, which is astonishing data that I read. And so, how do you continue to hone in on that balance reflex so that you can continue to maintain your mobility? So again, kind of that thought about both of those. So cognition as it relates to mobility just alone. So
Great, great. Well, should we hop into an audience poll here and see what people are thinking? Garrett, could you kick us off here?
Yes, let's do it. So you will see this on your screen, everybody. And by the way, we're going to do a couple of these. These are anonymous, so this is just for fun. And the first one is this. Which MSK-related challenge resonates most with your organization? It creates the most friction, cost, or opportunity for change. So you may be saying, well, gosh, all of these. But if you had to pick one, what would be the most? The the cost driver, the 380 billion annually, expensive interventions over prevention, the chronic pain plus aging, accelerated decline, reimbursement is volume based, not outcomes. How about uncoordinated care, especially for early stage pain? So we'll give
interesting.
folks,
Interesting looking at kind of we can kind of see where things are
yeah,
trending. And, it's there are a lot of big problems that we're trying to solve out there. And certainly in value-based care organizations, which I think is a majority of what we do. I think fee-for-service is becoming less and less feasible for
Mhm.
providers as well as other plans. And so, I think that that we'll talk a little bit more later about, how we align with value-based care. It's a world I've lived in for my entire career, so
Yeah.
I'm excited to get there. But
Yeah, we're close on these. Whoever hasn't voted yet, you've got a chance to be almost a tiebreaker here. So
That's true.
I'll give
Oh,
you
there we go.
seconds to
Uh,
get your last votes in here so that you can be heard.
yeah, I'm going to close it down in about 5 long seconds. Five, four, three, two, and one. And I'm going to go ahead and share the results. Okay. Dr. Baldwin, Ed, are you able to see the results on
We
your screen
can,
here?
yeah. Yeah, what a dead
yes, sir.
heat. There. I mean, first of all, Don, as you mentioned, these are all impactful, and everybody cares about each of these. But the one that was leading for most of the time, there was this idea of being volume based and not outcomes based. And I think we'll get a chance to talk about that. Well, we should talk about it right now because it's top of mind. I think all too often our system has been built around this volume based approach, especially in sort of an outpatient PT type setting. One of the trends that we're seeing here at Nimble is that kind of gone are the days where that PMPM or that volume really dominates, and more we see our health plan and health system and value-based partners saying, how are we going to measure outcomes? And how do we structure agreements and contracts so that it is truly outcomes based? So if there's great outcomes, it's a win-win on both sides versus a volume-based thing, which who knows how that turns out. I don't know, Donna, what have you seen? Kind of how are you seeing the landscape change around that?
Yeah, I mean, I love it. As a provider, I care about what happens to my patients. And I think that it's really important that whatever intervention I put into place actually matters.
Mm-hmm.
And so being able to be really thoughtful about quality and what outcomes we actually are measuring, I think is hugely important. And so I'm excited to see that as being high on people's list of what they care about. Lots of conversations around stars and HOS these days, certainly with fall prevention or falls being in that HOS space and how that is a growing part of STARS metrics. I
Right.
think it is really about outcomes.
Right.
It is about cost savings. It is about making our lives better for our older adults and having tools in which to be able to do that. So I'm super excited about that. The other one that looks high to me is that uncoordinated care.
Right.
I think healthcare is hugely fragmented. Whether you're talking about digital health, whether you're talking about PCPs, which we know are really hard to find, specialty care. I think there's definitely a movement towards really wanting to coordinate that care so there's not these silos that happen. We see that in urgent care, right? Our patients can't get in to see their PCP, they go to urgent care. Urgent care is, looking at this one problem, they're not looking at that whole patient. And so I think what I'm super proud of at Nimble is that we're looking at not just fall prevention and mobility, we're looking about the lives of our aging
Right.
adults. And so can we look at social isolation, with playing games with others? Can we look at providing, coach or companion care to really help these members with that, whether we're reaching out to our members that haven't gotten osteoporosis screening. So I think it's really looking at Nimble as more than just a fall prevention app,
Right.
and helping to coordinate that care with the health plan with our provider groups.
Yeah, and I think that's where digital solutions can be helpful here
Yep.
too, is you have something that's digital, maybe a little bit more quantitative, easier to measure outcomes. Digital, again, more flexible, maybe more scalable. You can kind of reach those people and coordinate things a little bit better. So,
Well, and I think making it easier for those care teams,
right,
right?
that's
The,
right.
the
Yep.
providers and the care teams have so much else on their plate to take care of that if we have an easy solution to be able to just say, hey, I really think you should download this app. I
Hmm.
think it'll be really helpful for you. It is a huge impact that we can
Yeah.
make.
Yeah. Well, thanks, Garrett. Appreciate you helping us, and we'll have another audience participation here shortly. But in the meantime, let's talk about falls. I guess one other thing I should mention to the audience is, we have the question field. If these kind of discussions spark any comments or anything that you see in your world, and you just want to put a comment in, please feel free to do that too, and we can talk about those as well. So let's hop into falls here because this is a big component to MSK that's often overlooked. We're going to talk about the numbers, which are really staggering when you think about it. First, let's look at a membership base. 1 in 9 of your members is going to have an injurious fall each year. That's something that's a fall-related medical claim. Somebody presents to the ED. It could be an orthopedic event. If it's even worse, you have an inpatient stay associated with that. Skilled rehab. It just goes on and on. But this is basically the stat: 1 in 9 fall each year, and an additional 3 out of 9 of your members are at high and emerging risk levels. So we like to think about falls as this continuum of risk where it's not just, oh, somebody's falling and these people aren't falling. Everybody is on some sort of spectrum here. And when we think about kind of that coordination of care and getting this out to populations, let's say true population health, this entire spectrum needs to be addressed. We can't do fragmented care. We can't have it purely be episodically based. This is where the P word, prevention, comes in. That's so important to this population health. So if we go to the next slide, what we can see here is the component of MSK spend that's attributable to falling. So you can see we started off with our title MSK cost on the left-hand side here, $280 PMPM. Falls on their own, $108 PMPM. Let's look at that intersection there, $60 PMPM of your MSK cost is attributable to falling. So a fifth, 20% of your costs are due to acute events. I think a lot of times, Donna, when we think about MSK costs, we think about somebody has pain, or kind of being reactive to that. Maybe it's not an acute thing. It's sort of this chronic, and how do we resolve that? 20% of your cost is driven by these acute events that aren't always predictable. We'll talk about that in a second. But if you're not upstream of that, doing true prevention, you can't impact this number.
Yeah.
I mean, what do you think about that?
No, I think that makes total sense. I think it's really tough to swallow that hospital visit or that surgical procedure for a hip fracture, and then the downstream effects, because that member is likely going to have to go to a sniff or something like that. And so the care, and then not just the well-being of that patient, because their family then is going to have to figure out how to take care of them, and then getting them back to where they were before, I think is often a challenge. So I think this makes total sense, and I love this graphic where it really lists it out.
Yeah, we like to tell people if you have an MSK strategy in place,
Mhm.
but you're not trying to preventatively deal with these events like falls, your strategy is incomplete because you're only addressing 80 cents on the dollar there, and there's a lot that can sneak through the cracks. Let's talk about what this looks like in a population of, let's say, 10,000 members. I always like to put numbers on this. So here's that $280 MSK spend attributable to fallers, $60 PMPM. Per every 10,000 members, you're looking at $7 million in cost a year. For those of you who are part of health systems, you're taking risk, you're in some sort of value-based arrangement, these become big numbers on a PMPM basis. Donna, what do you think? How should people be thinking about this?
Yeah, I mean, I think it's this puts, like you said, real numbers to it.
Mhm.
This is a slap in the face. I mean, this is so yeah, it's something that people should be really thinking about as part of their strategy.
Yeah. Let's go to the next slide. Another thing that we hear all the time is, I talked about the need to prevent acute events as part of your MSK strategy and getting upstream on the prevention side. One of the things, and we say if you don't have that, you have an incomplete strategy. We see the same thing here where sometimes people, they go straight to the high risk and they say, you know what, I'm going to intervene on my people already falling. And again, taking that 10,000 population here, there's different risk buckets, but we're going to focus on the two extremes because that's where people tend to go. They tend to say, I'm going to intervene on my fallers. That's the pink box here. In a population of 10,000, that's probably 10%, 1,000 of your members. They fall at a 36% rate, a 36% claim rate, quite expensive, quite acute, 360 injurious falls for that population in a year. People say, I'm going to go there. That's where the people are falling. What they miss is the opposite end of the spectrum because you have people who aren't at high risk. They're just kind of normative risk, but those people fall at a 6% rate. We all have the story of somebody who was, healthy and for whatever reason, suffered a catastrophic fall. They fall at a 6% rate. There's 6,000 of them, but there's so much more that when you multiply those numbers together, actually your cost and your falls are equivalent in those two groups. And what we see over and over again is people say, I'm targeting the pink box. I'm not going to worry about the green box. And we think you're missing something there.
Well, yeah, because your moderate risk is really where you're going to make the most impact, right? I think your serious risk, you can make some impact, but I would bet, if you really focus on your moderate risk, that's where you can make the impact and prevent some of those falls, probably more I definitely think more falls than you can at the
Yeah.
serious risk.
Well, and there's also downstream impacts to that too,
Hmm.
right? When you're addressing people who are, these moderate risk folks, they're living independently.
Hmm.
If they have a fall, they're out of that category,
Correct.
and they're probably not coming back.
Right.
So now you have a cost escalation, not to mention, any of your quality metrics, any stars for those of you who are, accountable to CMS and stars. I mean, this all plays into that. So it's not just a numbers game of preventing falls here. We have the entire, let's call it the life cycle of the patient to think about, and
Hmm.
how do we keep them in that bucket
Right.
as long as we can.
I'd love to hear what people's thoughts are on that.
Yeah, yeah. So let's good. Let's call in Garrett here. Perfect timing, Donna. We'll do another poll.
All right. As before, you will see on your screen. All right, a new poll. And again, these are, if you're joining us late, these are anonymous and they're just kind of for fun, and we'll show the results here. So the question is this. Now that you've seen the connection between MSK and falls, how surprising is this to you? And what is your reaction? And if you have to choose one, this says, I'm surprised. I feel like I need to take action now. Or this is interesting, but I don't view it as a priority right now. Or I'm already working to solve it. Where are you? And what we're going to do is we're going to wait till the results come in and we'll show the results here to you guys. And so you can see sort of where you stack. And this, again, this is anonymous, so you could feel like you could honestly answer. And it's just for fun. And so we will show this in just a moment.
We want
And it
better
looks like
participation than the last one. So let's
that's
get your vote.
right.
And
So it looks like most of them have come in. So we'll give it another maybe 5 long seconds like we did before, and then we'll close it down. So 5, 4, 3, 2, and 1. All right. Are you guys able to see the
Awesome.
results?
And I'm
yeah,
so much more. I'm so curious about those that are already working on it, working on how to solve it. Would love for you guys to put in the questions really what you guys are doing. I would love to hear what's out there, where people are finding successes, because I think this is a problem that people are wanting to solve. And it looks like from the other answers were pretty split.
yeah.
Um,
Yeah,
that
that's right. So I love that, Donna. For those of you who are solving it, if you could just put something in the
Mhm.
question, because we're getting, questions from people on what are people doing to solve it. And there's a particular question here about what measures are people using in VBC contracts, for MSK. And Donna, I don't know if you want to talk about kind of how you're seeing that evolve on the outcome side. I'd be happy to share well, why don't you?
Yeah, I mean, I think this really leads into our next conversation around how your fall and MSK strategy leads into your VBC metrics. So certainly aligning with value-based care metrics is important. So you want to focus on lower spend, right? You want to focus on quality metrics. You want to look at your patient satisfaction and your provider satisfaction. You want to focus on preventive care and coordinated care. So we've heard these words throughout the conversation, but this slide really looks at, are we on that slide though?
No, we're still on the poll. There we
Thank
go.
you.
Yeah.
Excellent. So really looking at how your fall prevention supports the metrics that matter to you. So certainly being mindful of what these are, and creating a strategy around that. Um,
Yeah, great question. Kind of from the specific nimble side, and I think that this should carry on to the broader MSK, is what we're seeing in the market is more and more. We work primarily with health plans, but it's really around ED and inpatient utilization
mhm.
and the cost that comes from that. And so looking at those two metrics, I mean, everybody's tracking those metrics. Everybody knows their ED and inpatient utilization. Can we reduce those? And that's a nice objective measure that I see that correlates with just about everything here. This is great. We got do you want to say
Yeah,
something?
so the other thing I would say, one of the things that we're going to be that we measure here at Nimble is really someone mentioned PROMs, right? So patient reported outcomes. And so I think that that's something that can really give us some good data
Mhm.
around, it has Nimble helped them, with their falls and their predictability. I think the other thing is that, creating questions that help us align with HOS metrics. That's something we're doing and working hard that. And then using PREMS as well, right? Our patient-reported experience metrics. So that helps us get to patient satisfaction. We're also going into clinics, right, and aligning with providers and their workflows and helping them have a better experience when they identify someone that has a fall, or even just using their whole population of Medicare Advantage members, because there's lots of people that can benefit from this. So
Right. Thank you. Here's a great question that came in. Here's a care coordination nurse who says, people sometimes have to wait 4 to 6 months to see a tier 1 provider. Of course, things worsen in that time. What are the short-term solutions? What alternatives? I mean, you must see this all the time with patients.
Yeah, I mean, I think, having the entire care team engaged is really important. And so again, having really easy tools and things that they can recommend. And sometimes, that can be really helpful. So,
Right.
I hear you. I think it's really frustrating to not have those tools and easy and tools that patients will actually use, right? Again, back to what I was saying earlier, it's really hard to encourage them to go to the gym. It's really hard
Right.
to encourage them to walk around the block sometimes. And what is that accountability tool? So, really having a program that can help, that has those outcomes demonstrated, I think is really important.
Yeah, to me, Donna, this ties into that upper right-hand block there on health equity.
Yep.
Because I think that access is a big driver and a big component to health equity. And, what we see is a lot of people who are in rural and frontier areas, may not be able to even get to that tier 1 provider. And, I'm obviously biased because I work in digital health, and I don't think digital by all means is the end all be all solution for everything. But I do think there's an opportunity here. How can we get care remotely into the home? And at different levels, right? You can think about an in-home visit. Well, that's one tier. But if you get down here to being able to deliver, educational materials, content, even targeted programs into the home via digital means, we've seen some of our partners be able to really move their metrics on health equity, and I think that's an important component here for people to think about.
And I think you have to be really careful because you really want to make sure that digital health solution is coordinated with the healthcare team, right? It can't be done in silos, which means, the digital health program has to be responsible for working together and partnering with the care team to make sure that we're addressing the digital health program is addressing everything it needs to be addressing for that particular problem of that patient population. And so really that integration is, I think, is hugely important, again, to coordinate. And you can see that on the right hand side at the bottom.
Yeah, absolutely. Well, you guys are all coming alive here and sending in some things. I love it. There's a point here about defining moderate risk versus high risk versus emerging risk. We take a claims-based analysis to this. We've developed some actuarial models on the fall side. Your highest risk people are those who are known fallers, who have fall-related claims around that, often broken bones. You tier down one level. These are people who have claims around, maybe they were at the ED and they have a sprained wrist that's consistent with a fall, but it wasn't some sort of thing that requires an inpatient stay. So they're kind of one tier down. You suspect they're falling, and they're probably on that path. And then you get to sort of the normative people who have no known risks. We say no known risks in the claims data, but of course you start looking at pharma data. Okay, if you have polypharmacy, now all of a sudden that's a risk. If you live in a place with stairs or winter conditions, whatever. So there's all these things that contribute. So to the person who asked the question about defining risk, we spent a lot of time, getting this right and just understanding how do you bucket people, and different buckets of people need different solutions, right? There's not always a one size fits all, and it depends where they are in their journey. So thank you for these questions. Donna, let's talk about, let's pull it back to sort of real people. I know we're at about 30 minutes here. So I'd love to just talk about this and kind of, take additional questions or comments people have. But, we love hearing from our Nimble members. And this is, an example of when you intervene sort of proactively on that MSK side, on the fall side, this is what you get. And, here's Teresa, who's 90 years old. She used to walk with a walker. Now she walks without help. And you see this phrase, we see it all the time, I'm living again. That's the thing. You talked about experience measures, right? I think a lot of times we focus so much on those objective measures. When you have somebody who has the experience of then living again, look at all the downstream impacts. In some ways, that's the most important thing. They feel confident moving, they're living again, they're socially engaged. They're getting to their doctor appointments. They're getting to the grocery store. They're buying healthy foods and all of that. So, this just warms my heart to see these things, and I love reading them. I don't know if you want to talk
Yeah,
about David here.
I mean, I think it's really not just about fall prevention. Really, it's not just about improving mobility. It's around changing their life, and
Mhm.
and you can see this from David, right? It's not just about being able to do that, but really increasing confidence, independence, and really mindset. And so, oftentimes I would see patients that were losing that independence
Mhm.
and then starting to get depressed,
Yeah, right,
right? And then we know depression has a cognitive effect, and
right.
so again that cognitive effect then kind of multiplies their inability to maintain their mobility. So I think again, whole person care, right? And really being able to address, not just one aspect of their health, but
Right.
really from a mental capacity, from a physical, from a social. So I really think, the impact that you can have in this very small fall prevention,
Hmm.
I think really addresses some of those other things. And that's something we ask our patients, right? And so, we don't want it to just be about falls. We want it to be about the other, stars and HOS metrics, that it's more about their physical and their mental health, because there's such that impact, right? There's
Hmm.
that cognitive aspect to balance,
Right,
that I
right.
think that we shouldn't overlook.
Yeah, and I think this mindset just triggers for me. What's the biggest predictor of a fall is a previous fall. What's the second one? A fear of falling.
Yep.
And like you said, when you start to become fearful of things, then all of a sudden that person sits in their chair all day.
That's right.
And that starts that cycle of degrading, and now all of a sudden they can't leave their home. They've lost muscle strength. Most importantly, they've lost confidence. So, to me, this is a takeaway for all the people here. We talk a lot about outcomes and those quantitative things. I think focusing on the qualitative, that member experience, that member confidence, and their ability to feel like, wow, I'm in control, I'm empowered, I can live independently. I think bringing in solutions that promote that mindset have just as much of an impact as the ones that have sort of that rigorous quantitative approach. So, Donna, I don't know if you want to wrap us up here with some key
Sure.
takeaways.
So, MSK spend is high and falls are certainly hidden. So, hopefully, we've made the case for that. Not that you guys didn't know that before. But, knowing that falls are predictive, they're preventable, and there's action that you can take on it. And which patient should you be focusing on? And really thinking about that. Certainly, the traditional MSK solutions, in my opinion, in my experience, are fragmented and reactive, and really don't get at the prevention, and
Mhm.
which is so important that we all align on, in a VBC environment. Um, Really considering fall prevention as an MSK prevention and as a
Sure.
part of your strategy. So hopefully we've achieved all of our goals today, and hopefully you guys have gotten some good information and maybe even some foods for thought.
Yeah, and we have a couple more questions coming in here that we can wrap with. Donna, here's one. What innovative or underutilized services have you seen other healthcare systems implement that have meaningfully impacted PMPM costs for MSK? One company that I came across a couple weeks ago that's having impact here is sort of a navigation approach. But instead of what they're seeing is, well, somebody shows up here, it's the fragmentation. They get referred, they have an MRI, then they come here, then they're bouncing all around. What these folks did was connect people to a telehealth visit with actually an athletic trainer
Hmm.
who looked at their range of movement and said, okay, show me what's going on here. And they sort of coached them through, oh, based on this, it's probably that. And they could help direct them to the right care. An MRI isn't right for everybody. Of
Right.
course, everybody wants an MRI because who doesn't, I
Right.
guess. Uh, but kind of directing people to the right care. And I guess it's taking away that fragmentation
I would bet
that
it
we've seen.
also reduces spend, right?
Yeah,
Because
well, that's right.
maybe that
That's right.
MRI is avoided in an unnecessary diagnostic testing.
Exactly. Exactly. Let's see what other things here we have. We do have a question about, can you spot somebody who's at risk for falling? And then a question about, use of technology. We talked a little bit about digital. I think I'll kind of come back to my answer on, can you spot somebody who's at risk of falling? To some you can, to some you can't. And I think that's the importance of kind of that population wide preventative care. But it really comes down to that fear. When older adults become fearful, and when we as a system kind of embed that fear in what we're doing. In other words, we tell people what they can't do versus what they can do. we kind of perpetuate that vicious cycle. And so I think to the earlier question, what interventions, I guess this isn't a specific intervention, but it's just sort of a tone, is when you lead with fear, it causes fear, especially when it comes from an authority figure like a physician or a clinician.
Which is really what's underlying most people when they come to see me.
Yeah.
And so identifying what
Right.
that fear is, I think, is really how you can be a successful clinician.
Yeah.
To really understand what that fear is. Is it a fear of, I'm not going to be able to make it to the bathroom because I'm incontinent? And so, how important is that to you? Obviously, those patients are at risk of falling too, but, really understanding that as a provider, I think, is really key to being impactful in that patient's life.
Right.
I love this question on, do seniors use tech? We certainly think of our older adults as maybe challenged in our tech, and I think that that's a myth, to be perfectly honest. In a previous life, I worked in digital health, and we didn't even market to Medicare Advantage patients, and yet we saw a huge uptick. All of us went through COVID, and so all of the grandmothers were FaceTiming with their grandkids because that's all they could do. So I think we've really seen an uptick. I think we can get 20% engagement with our members, and that's huge. So I think it's truly a myth that we can blow up quite easily.
Yeah, yeah. So we got older adults using technology. We had the opportunity to kind of change that mindset, get out of the fear-based approach, thinking about kind of true collaborative care that's not fragmented, that navigates people to the right places. So, well, great, Garrett. I'd love to turn it over to you for some closing comments. Thank you all for the questions, and it was a terrific discussion. I had a ton of fun here.
Me too.
All right. Well, this was a fun discussion. I'm really glad you guys came on, and we got a lot of audience interaction here. So again, if you have a question that's come in to your mind here at the last second as we're wrapping up, go ahead and drop it in. Someone will reach out to you via email to make sure that we get your question answered. As we close out, I wanted to encourage you all to check out the virtual exhibit booth for Nimble over at bbcexhibithall.com. So if you go to bbcexhibithall.com, and also there'll be a direct link here in the slides that we send out, but you can go here and read up on them, some resources that they've got, and really educate yourself, and so that you can reach out directly there. Or if you would like to directly reach out to the Nimble team, then yeah, here we go. Their information is here on this last slide. Feel free to do so, or I'm happy to facilitate an introduction as well if you would like to reach out to me. But I know they'd be happy to talk and sit down with you guys and go through whatever might be helpful. So thank you all again so much for spending your afternoon with us. I know we're wrapping a little bit early, so enjoy your extra 20 minutes to your day. We won't tell. But I hope you will join us on the next one, and stay cool out there because it is really hot in a lot of parts of the country right now. So thank you again so much for joining us. Dr. Baldwin, Ed, thanks so much for a wonderful presentation. We'll see you guys on the next one. Bye-bye now.